Hello there. Thanks for watching. Today's mini talk is going to be about the Amplatzer Amulet device. It's a newer product here, and since we might be scanning these patients more at the hospital, TKC, and structural heart, I wanted to give everyone a heads up. This mini talk is going to cover briefly what is it, how does it work, left atrial appendage occluders, what we may see, what next, and when to notify a physician. Okay, what is this new device? I will read from the FDA and Center for Devices and Radiological Health's paper on this device. The Amplatzer Amulet and left atrial appendage occluder is a permanent implant that is placed in the patient's left atrial appendage, which is, as we all should know, a pouch-like part of the left atrium. This pouch-like appendage is also where blood clots like to form when a person has AFib. The device is intended to prevent clots formed in the left atrial appendage from entering the bloodstream and potentially causing a stroke. How does the clot get out? Maybe the patient self-converts from AFib to normal sinus rhythm, or perhaps they have a few PVCs causing the clot to break free from the appendage and travel to the brain or other organs. This device is made of a nitinol mesh with a polyester fabric. Nitinol is the same material we use in the Medtronic core valves. So what is this device? It's a plug for the left atrial appendage. How does it work? A physician inserts a delivery catheter into the blood vessel in the groin and advances it to reach the right atrium. A small hole is made in the inner atrial septum so that the catheter can pass through to reach the left atrial appendage. This hole can be Dopplered for some time after the procedure. It heals up on some people right away, and not so much so on others. When the device is positioned properly in the appendage, it covers the opening of the appendage, and over time, a thin layer of tissue will grow over the surface of the amulet device. This keeps any blood clots formed in the left atrial appendage from entering the bloodstream. This tissue is also called pannus tissue and is the bane of prosthetic valves. Left atrial appendage occluders. We really only see two of these devices here, and they are B and D. The Watchman is the most common, and I cannot tell you if that will change. In D, the Amplatzer Amulet device is what we'll be looking at here in a second. When we see new devices, we don't always know what they will look like on echo, and they can be surprising and downright scary if you're caught off guard. And that's what happened to one of our sonographers when they scanned a same-day discharge patient. The sonographer contacted Regina and me, and when we pulled up the echo, I thought I was seeing an emergency in progress, and went ahead and called the implanting doctor. What we might see with the Amulet device? This is what we saw. Honestly, I thought I was looking at a PFO occluder device that had slipped out and become lodged in the left atrial appendage. After speaking with the interventionalist, I was reassured that what we were looking at was a normal variant. And if you look closely, you will see the device moves with the heart, and not like blood flow or causing it to move. Here in the 3-chamber, the device is well visualized and is not moving on its own fruition. I just want to take a second to appreciate this cine loop. The occluder is well seated, and I would like to see the device in a year and if pannus had grown over it. Here we see a 4-chamber and a 3, and this patient was done the same day with the same device. But as we can see, or not see, the device does not show up the same as the previous slides. If you look closely, you can tell there is a device in the heart, but it seems nothing like the previous slides. In the next slide, we will see a TEE cine loop with an embolized Watchman device. I hope we never have to image anyone's heart like this here at UAB. In this slide, I will quickly go over what a simple prelim may contain. This is not the only thing you will put in the preliminary report, but it is necessary. In the history section, we are going to hand type device brand name, in this case Amplatzer, model name, Amulet, and then the size and date of implant. For the reason for the study, if the option is there, left atrial appendage occlusion. Otherwise, pick the next best option. In the body of the report, under the left and right atrium tab, in the left atrium section, we will hand type again, like the histories, device brand name, model name, size, and implant date. If you can see the device and it's not moving awkwardly, we will say well seated. If you cannot see the device, we'll say not well visualized. There is often a residual interatrial shunt after having a left atrial appendage occlusion, and we should interrogate it with Doppler. You're looking to see if it is left to right and how large it is qualitatively. This shunt closes over time in most instances and is nothing to worry about, but as always, be sure to mention its visibility and direction. Finally, don't forget to mention if there is any significant changes in MR, TR, and RVSP. We shouldn't expect any hemodynamic change, and that is why we should note it if there is any. Making a note of hemodynamic changes brings us to when to notify a physician. If there are significant hemodynamic changes or compromise, notify the physician. If the device is visibly rocking or embolized, I would page the implanting doctor right away, if this is a same-day discharge patient. It would be UAB policy to page the reading doctor and such at any other time. If there are new wall motion abnormalities or pericardial effusion, you should page the reading physician. These notable concerns do not happen often, and we should hope to never have to image any of this. These references, this is where I got most of the information that I used for this little mini talk. If you'd like, we can have links to them, which are right here. Both these links were pretty helpful to me, and they'll probably be helpful to you. Anyhow, thank you guys for watching. I hope to put more of these little mini talks out soon. Anyways, ciao.